you. Good morning. Apologize, I don't have a microphone today beyond the camera, so I'll try and yell if you can't hear me. We're going to keep this pretty informal, so please raise your hands, ask any questions. Basically just springboarding off the patient talk so you guys can hear what we tell patients on the back end with a couple additional slides and routes we can talk that are more pertinent to what you guys do on a daily basis. So as we talked about, train here, went to Boston to learn some of the latest tips and tricks. Where I train, it's an orthopedic-only hospital. They do about 8,000 joint replacements a year, so it's really built to be a manufacturing center of all the latest techniques and advances, and we're trying to bring a lot of those same type of concepts here. When you do really one thing and one thing well, it gets to be very predictable. So for arthritis, I tell patients, realize you're not alone. There's 43 million patients that have arthritis to some extent, 60 million by 2020. We do have 2.5 million people walking around with an artificial hip and closer to 5 million now with an artificial knee. By the time you're age 80, 6% of patients will have hip replacement, 10% will have knee replacement by 80, and certainly arthritis gets to be the most common cause. So arthritis, I tell patients, just wear and tear. It's nothing they did wrong. Weight certainly contributes. Any prior meniscal tears or cartilage soft tissue injuries can certainly predispose patients to that. But sometimes we get one knee, one hip that gets arthritis and the other one doesn't. It's hard to say why unless we have an injury in the past or an anatomic reason. Rheumatoid, as you know, is autoimmune. We don't see that, thankfully, nearly as often as we did a decade ago. Particularly the more advanced rheumatologic medications really seem to head this off. So we occasionally will get a juvenile that's resistant to those type of medications, but very rarely do we see runaway rheumatoid arthritis. Post-traumatic and AVN, again, smaller subset, AVN related to medications, heavy alcohol history, chemotherapy, steroids, multiple other reasons can cause that, and basically it just turns into eventual arthritis once that head collapses. 7 million joints total, again, walking out there. So we tell patients this isn't the end of the road, this is a new beginning for you, and you're not alone. We're going to talk a little bit about joint pain, the treatment, historical to modern day, realistic expectations, and these keep getting higher and higher every year. People aren't just looking to walk anymore, and some of the technology and robotic advancements that we do have available here now. 375,000 hip replacements are performed each year. That's rapidly rising. Why? Most common is pain and disability. So I always tell patients this is a lifestyle choice. This isn't like your heart and lung where you have to get to it. This is something that if it slows you down, impedes what you're trying to do on a daily basis, we can get you back to doing that. Arthritis is really worn out cartilage. I use the tire analogy in Metro Detroit, seems to work well. You got an old tire, you certainly can drive your car on your rims, it's just not a smooth ride. So it's ultimately a lifestyle choice. A lot of patients notice restriction in motion early on, bending, flexing, twisting, putting their socks and shoes on. Eventually, even sitting, stairs, putting on their socks becomes difficult. The twisting maneuvers getting into a car difficult, particularly with hip arthritis. Specific activities patients want. Younger patients, baby boomers, don't want to give up the athletics, so they want to go out and play basketball on the weekends and get on the elliptical after work and do athletic events. Some of our older folks just want to bend over to pick up their grandchildren comfortably. So everyone's got their own goals, and the goal is to try and get these people back to doing those type of things. Symptoms, they can develop very slowly or rapidly. Patients may relate, I did this, I twisted my knee 2 weeks ago and it's been downhill since, or the rarity, I had a car accident 6 months ago and it's never been right and it's because of the car accident. Usually it's acute on chronic injury. So people may relate one injury where this occurred, but it didn't happen overnight. Wear and tear arthritis takes many years. Sometimes it just takes one particular incident to bring it out into the forefront. Some can cause swelling, particularly the knee. That's pretty obvious to see, and the hip, it's pretty deep. It's difficult to tell without an MRI if there's swelling there. And again, simple daily tasks and the ADLs that people struggle with can become difficult. The hip, we tell people treat the symptoms, not the x-rays. So some people come in with terrible looking x-rays and they don't hurt. That's really the panacea, is trying to figure out how to get these people functionally to do well and not hurt. And you can live with arthritis. Unfortunately, most people with arthritis do eventually hurt, and that's where the treatment comes in. And I always tell patients only you can tell when you're ready. I can't diagnose that. So they come in, look at the x-ray, I can give them a guesstimate, saying I think in the next 1 to 2 years you're talking replacement versus 5 to 10, but there's really no right and wrong for any particular person. I always tell patients, learn about it, get educated, go away, see how it does for a while, and eventually you come back and they come back and say, yeah, I know now is the time. That's a different threshold point for every patient. So in the clinic, certainly do an exam for the hip, moving around, twisting is one of the best maneuvers. To figure out, does it jive with their x-rays? You see a normal looking hip up top here. The arthritic hip on the left is one of the reasons we know women start to get arthritis, hip dysplasia. So if that ball and socket, if the socket hasn't completely grown over to cover that ball, you get a lot of edge loading. So the pediatric hip looks like this, and eventually as you mold into an adult, you get better coverage. We know a subset of the population doesn't do that, and that's hip dysplasia. Again, this is just one of the reasons women get earlier arthritis. Most of the causes of arthritis, we don't have a particular reason. These are just some of the reasons that we know why people get it. On the right here, they talk about cam lesions. Particularly our men seem to get this. So if you look right here, the ball bearing's no longer round. You got this little hump right here. So that hunchback portion, when you go to bend over, put your socks and shoes on, eventually you get to the point that that bump starts scraping on the edge of your round socket. So you have an oval ball bearing in a round socket. Eventually you start scraping off the upper edge and creates arthritis throughout the joint. Again, we don't know why this happens. There's some basic science and theoretic studies, particularly because it's common in males, that heavy athletics in the teenage years may cause some growth plate stress asymmetry to where it grows to be a little bit more of an oval. But again, that's somewhat speculative at this point. Treatment is medications, anti-inflammatories are the best. I like Aleve, but anything long-acting. The people that take Motrin, you need to take it every 6 hours to be in your bloodstream, and no one can remember to do that. So I steer people towards Aleve. Kind of the poor man's prescription is if you take Aleve over the counter and you double it, that's the prescription strength that we give patients in the clinic. So if you ever meet anyone in a pinch, just tell them to get over the counter Aleve, double it up, assuming their kidneys are okay. Tylenol is good for those with bad kidneys. Physical therapy is good, really only for our deconditioned patients. Muscles are the shock absorbers for the joints. So if they're not very active, difficulty walking, couch to refrigerator, then those patients may benefit from it. But if they're out in the community working, usually it's not going to get them a significant relief. Injections, again, are temporary, but they're the mainstay of our non-operative treatment. Real easy to do. Knees we can do in our clinic. Hips need to be done under ultrasound. There is some of our sports docs that have that capability in clinic. Usually we just have our radiologists or pain colleagues do this. Every 4 months is the magic number for steroids. So steroids are just a potent anti-inflammatory, goes into the knee. Get a lot of patient questions that steroids have a bad name in the community, and they do if you take them in high dose orally. But the small dose that goes in the joints is very minimal. So by the time it leaches out in your bloodstream, it creates very low secondary complications. Diabetics occasionally will get a spike in their sugars for one day. You may see that if you catch them right after that. Usually within 48 hours, it's back to normal. 4 months, every patient comes back for an injection unless it lasts. Eventually, the shot may last a year. They come back one summer, then the following summer. Each shot tends to last a little less than the next one. Eventually, you're under 4 months. That's usually when I talk to patients about replacement. I educate them earlier in the route so they can make that decision, but once you're under 4 months, you back yourself into a corner. Viscosupplementation, or the jelly shots, chicken shots people ask about, 5-10 years ago were much more popular. We thought they actually did something. When we have a lot of non-biased studies now where they're not paying the doctors to say it's great, we realize they're probably not all that great to begin with. Compared to a steroid, there's really no difference. So our Orthopedic Academy has come out a couple years ago not recommending their use, meaning there's no evidence that they do anything. That being said, they do work for a small subset of patients, but it's a series of shots, so it's between 3 and 5 shots, and you have to get them weekly. So I always tell patients that want them, I can give you a one-time steroid shot and you're done, or you can come back multiple weeks in a row, use a somewhat expensive medication that has been shown to be no better, and most people lean towards a steroid. Hip replacement, again, is the ultimate solution. Very rarely hip resurfacing. We can talk about that separately, but I can tell you men under 55 are really the only patients that it's approved and indicated for now. So anytime you see a procedure where it's really being whittled down to a small subset of patients that may or may not do better, you got to question it. I can tell you the 4 or 5 implant companies that had this hip resurfacing out, all but one has been pulled off the market for a metal and metal reaction. So anytime you have a metal and metal bearing, you can create some problems. One company seems to have the engineering down a little better, has less complications with that, but it is not non-existent. And the old adage with hip resurfacing was it's minimally invasive. I can tell you, having done some, the surgery is maximally invasive. You actually need to take down more muscle, more exposure. I've done a total hip on multiple patients that have had a hip resurfacing on the other side, and they agree that the recovery is a lot quicker with the replacement. You can deal with smaller parts. Once you take that ball out of the way, you can deal with small portal incisions versus a larger incision, larger exposure, take down muscle to cap that bone. The x-ray makes it look like it's minimally invasive, but all you're really doing is saving that 1 inch of bone. And in the event you ever needed to revise that to a revision total hip, that was the goal down the line. That 1 inch of bone really isn't utilized anyhow. You'll bypass that and go down into the shaft, the thigh part of the femur there, so that upper inch of the neck really doesn't play to be a major factor. The good news is most hip replacements are lasting 20, 30, 40, and theoretically longer now, so I don't think we're really planning on doing the next step, but we're always making that available. If you go back in history, early 19th and early 20th century, hip replacement began in its infancy. We started off with resection. 1940, the girdle stone for OA was used, and a lot of this was from the experience of tuberculosis. So in the early 1900s, tuberculosis, more of an issue. People used to cut out the head, like you see this picture here. It looks bad on x-ray, but it actually eventually doesn't hurt very much. It's not very functional because the leg is 4 to 6 inches shorter, but you do form a lot of scar there, and you no longer have bone rubbing on bone, so these patients actually feel pretty good. Usually they have to have a good other leg and be able to transfer, but this was the main treatment for tuberculosis as well as arthritis at the time. In 1926, they began fusing to try and prevent the bone-on-bone rubbing. You fuse the bone into one solid bone. Gives you that length, kind of a peg leg, but it works. Mold arthroplasty in the 1930s and 40s became popular, particularly Smith Peterson, who was one of the original guys where I trained, came up with this, and believe it or not, they actually used glass. So it's a little glass cup, a little coffee cup, if you will, that covered the bone. Obviously, glass didn't last very long, so it would break. So they tried different alloys, ceramics, plastics, metals. But eventually, he was at his dentist's office talking to him about dental metals, and Vitalium was more popular in the dentist industry. It's very well tolerated by bone, and that became the mainstay. So they made these out of Vitalium metal, and you can see those x-rays there. And you know, years ago, I saw one of these that was 30, 35 years out in Boston, was actually walking around doing well. They were here with arthritis on the other side. So these do hold up, believe it or not, somewhat. In the 1940s and 50s, Austin Moore, Harry Bowman came up with the endoprosthesis, and that really was the beginning of the concept of hip replacement. These were more for arthritis and hip fracture. You take out that broken ball. We know it doesn't heal when it's a femoral neck fracture, and you replace it with a stem that goes down the thigh shaft with a new ball. In the early 1960s, this became used in other countries more so, but mold was still preferred. It was a little bit more predictable, but it was gradually changing. And we occasionally will see these come from other third world countries where these type of ancient implants are still used. They do have a decent track record. 1960s, John Charley, British gentleman, has really coined the father of modern joint replacement. A lot of what we do today is attributed to him. His experience was really with TB patients, and he said, well, I've changed the way we're treating these. Let's try this with arthritis patients. He came up with the low friction arthroplasty, which is basically metal on plastic. Even with metal on bone, eventually you get some discomfort. So he thought the metal and plastic would protect that. Ball and socket type of joint, and the body creates its own lubrication. Obviously, there were difficulties with the metal and plastic at that time, but the concept was still sound. And believe it or not, he was the first one that talked in surgery about infection and sterility. You probably shouldn't be smoking cigarettes and operating on patients at the same time. People were doing that. And sterilizing instruments, keeping room traffic to a minimum, using gloves rather than your bare hands. So a lot of innovative concepts here. Dr. O. Frank was, again, the first gentleman. Actually started my fellowship decades ago in Boston. He had the first American design, and again, improved some of the things that Charnley did a couple years afterwards. We had better metals. The metal neck was not snapping. The actual metal would break back then. Used a larger ball, which would pop out and dislocate less, and certainly plastic was evolving. It was very crude plastic at the time. So improvements in materials, wear rates. We were cementing all of these, and a lot of the Canadian contingent and European crowds still cements these. The problem with cement in the stem particularly is it's like grout. So I just tell patients anywhere in the body you put cement, it's a grout. It's not really a glue. It glues itself to the metal, but it gets into the pores of the bone. So just like any grout, eventually motion, remodeling of the bone causes it to loosen. So if we use non-cemented, the back of these implants, the metal has a rough sandpaper type of texture to it. Bone actually gets tricked into thinking it's bone, and some of the substrates actually under the microscope are engineered to look like bone, and bone will grow onto it. So once bone grows onto it, it's an evolving organ, if you will, and it constantly remodels and re-strengthens itself, and it doesn't loosen, so it's very predictable. And surgery approaches, minimizing muscle trauma to maximize the early recovery, and pain control and rapid recovery has really been the advancements in the last 5 to 10 years. Surgery itself is really only less than 2 hours once you pop the hood and get in there. There's a lot of setup before and afterwards, of course. About 1 night in the hospital is average. We are doing some outpatient now where you go home the same day. Really now with patients getting to the floor functional, we're able to walk them that afternoon. If patients do well with the halls, we have them go up the stairs. If you hit the stairs, you've really done everything you need to do to be in the hospital. Most patients mentally are not quite prepared to go home. They stay overnight, but I think we're getting there, and we're seeing a lot of surgery centers across the country do this outpatient, you leave from PACU. So it's definitely coming to the Midwest, and functionally we know we can do these. I think hips are the easiest because generally in our therapists see this, hips do very well, regardless what you do. PT, strengthening at home, and then eventually in the office is our current protocol. We do have some restrictions on position. We usually just use them for a couple weeks post-op, and we'll talk about this a little later, but they are becoming historic. A lot of the newer studies are showing, regardless of the approach, you don't need to use these. Obviously, different surgeons have different comfort with dislocation risk, so we're still kind of walking in the middle currently. Most patients are off a cane or walker within a couple days to a couple weeks around the house, and by 3 weeks they're driving. Just a quick video here of what hip replacement entails. Everyone's got internet and YouTube access now, so if you actually want to see the surgery, you can go on and look at it. If you've got patients, tell them to wait till after surgery. It sometimes terrifies them before. So metal ball, plastic socket. This plastic's really been the main improvement. It should be lasting many decades longer. In the 1980s and 90s, that plastic would wear out after about 20 years. And when the plastic was wearing out at the time, the metal would loosen. It caused very reactive particles to float around the joint. Now, 13 years out, the plastic we have shows microscopic wear, really unmeasurable with our techniques that we measure. And the thought is, if it does wear out down the line, we might be able to just do a tire exchange, meaning the metal shouldn't loosen, the plastic we can always change out. This is just an example of a more minimally invasive approach. It's all based on leg positioning. You can see when you take out that ball, you've got a lot more room to work with through a small incision, small muscle portal. If only it was that easy. Approaches, to talk about it, if you look at this top picture here, you got side hip, looking at my hip this way, so we got anterior, lateral, and posterior. Centers around the gluteus medius, which is again deep in that picture. Lateral was really the easiest and original, one of the original approaches where you went right in the middle of that line there. You took off the gluteus medius. Eventually it came to more of an anterolateral, and only took off 1/3 or 2/3 of that. We realized the gluteus medius is the main abductor, the one that causes the limp. When you get up from chairs, do stairs, it's really important that it's fully functional. And anytime you take it off, it occasionally wouldn't heal. So a lot of surgeons have abandoned the direct lateral. Certainly even anterolateral is falling out of favor because the goal is not to really touch and mess with that medius much. Posteriorly, you can look at that posterior line. It goes by names of posterior, mini posterior. So we're used to use 8 to 12 inch incisions. Now most people can get by in 5 to 6. There's also a variant of that called superior, which is direct superior, super path. And that's something I've been more partial to, or you can just really use that back third of a posterior incision. So if you look at this yellow line up here, you're not really coming into the IT band, you're splitting muscle with your fingers. You're not really cutting much from that standpoint. And the external rotators, the smaller muscles that are less than your pinky size-wise, we don't have to take those down Not sure it makes a huge difference if you do, is what some of the studies show, but the goal is to do as anatomic of an approach and anatomic closure in the way out as possible, and it makes sense to me. That's how we're able to get through small incisions. From the front, anterior's got a lot of press lately. I can tell you anterior is one of the original hip approaches. The hip's right there in the front. 50, 60 years ago, that was one of the main approaches to get there for infection, also replacement. Problem was the implants and the metal was longer. So anytime you're coming from the front, it's very hard to get down the thigh bone. That's why it's more ideal for skinnier patients. People with big bellies, it's hard to turn that corner. Goes by the name direct anterior, anterior supine and muscular. It's got a lot of play in the words there. But if you look, traditional incisions either from the side or in the back, this is from the front. The front's good because it's intermuscular, so they advertise that you're just spreading muscle, not cutting it. Having done some, I'd argue that you're pulling on that gluteus medius so much it looks like dog meat at the end of the case. There is some damage there depending on how you do it. And oftentimes to expose the femur, some of those external rotators end up getting released anyhow just to get access to it. One of the downsides in the anterior, I tell patients that are interested in it, is femoral fracture. Multiple studies have shown a little higher risk of fracture. It's hard to get down in the thigh bone. Now that the implants are getting shorter and smaller, it's a little easier. I think that's why we're seeing it more reinvented. And this table, about half the surgeons use the table, half don't. You still can do an anterior without it, but it allows you to hyperextend that leg, get access to that thigh bone, which was always the downside of that. It's a great exposure for the cup side because you're staring right at it. Regardless, most of the studies have shown no difference. We thought originally anterior did better early. We know by 4 to 6 weeks there's no difference. Then there were some newer studies, particularly a big one out of Mayo Clinic, that showed at 2 weeks with a mini posterior, less patients were using walking aids than the anterior. So I tell patients that everyone's posterior is a little bit different than the guy down the road. Everyone's anterior is a little different than the guy down the road. So pick your surgeon, not your approach. Particularly surgeons that are jumping to different approaches just for the marketing aspect, I think is not a great option. Those are the ones that are getting some complications. There's also a very big registry study that U of M published in Michigan. So we have marquee data now. It creates databases for the last couple of years of all the approaches, all the surgeries, how they do for 90 days. And again, showing no difference anterior versus posterior as far as length of stay and things of that sort. And again, just a picture here, hip from the side, looking at all the different approaches. You can see about 5 different lines there, different variations. And 10 years ago, there was actually a mini 2-incision hip where you, rather than taking 1 incision that long, you took 2 that long and spaced them out. You added them up, it was really the same incision anyhow, and again, had a higher complication rate. So thankfully, that's kind of gone away. But I think most of these are going to be here to stay. Direct anterior does have some utility. The posterior variants, again, have some utility. And the superpath approach, again, with some in situ net cuts, is a different way of doing things, but it's a very similar type of concept of not damaging that gluteus medius. Switch over to knee replacement. Again, less than 2 hours surgery, about 1 night in the hospital. We are getting some outpatient. Just had one go home yesterday, outpatient. So about once a week, it seems like we're getting 1 patient that will be up to go home that day. Usually it's the first case of the day. They have surgery at 7. So by mid-afternoon, they've tucked in, they've had lunch, they've walked the hallways, usually doing stairs. Mentally, if they're okay with it, is not a difficult point. Then it's just a matter of getting their spouses and family to agree it's safe to get them home. And we know now that it is, particularly since we got you guys helping out the next day. And if you ever see those last-minute urgent orders, it sounds like it's been taken care of nicely. That's for someone that went home the day of surgery and anticipates. So we'd like you to see them the next day if possible. More for the social aspect. They're just getting their feet underneath them, learning what to do. And we do give them some teaching, but it's a lot to go through in 1 day, obviously. Knee replacement, again, normal arthritis. I assume a lot of you have seen some anatomy, but when you hear meniscus tears, since that's the most common before arthritis, this is the meniscus. It's padding between the bones. There's one on each side of the knee. It looks like a round rubber washer or gasket. As you get arthritis, you tear that down. So people that get meniscal tears get little pieces of meniscus torn. When they bend, walk, pivot, and twist, if those pieces get caught in the joint, that's a problem. Pills, injection therapy are the initial mainstay, and eventually arthroscopic surgery just to clean out that portion. We'll get them temporary relief. In the 1970s and 80s, early, they used to just take it out because it was just in the way, we thought. We do realize now that creates a problem. That padding does eventually when it's gone, cause arthritis. So current meniscal surgery is minimal, just taking out the part or fixing it if it's amenable to that, because we know most patients without a truly normal meniscus will end up with this picture on your right, which is arthritis. So the goal is to prevent that. You can see the x-rays, you got padding and space between the bones. On the right, not much padding in the inner half of the knee. And that's an example where it's really just one side of the knee, the other half is preserved. That's where we get into partial knee discussions. The historical aspect, again, not as elaborate. 1940s, they did interposition, which makes sense. Patients still ask for this at clinic at times. Can you just shove a piece of plastic in there and create some space? Your x-ray will look normal. Create that space that you need to function. Problem is they'd spit out. Can't really keep that in there reliably. They did do mold arthroplasties in the 50s. Again, didn't work. But this is right around the 60s when John Charnley's hip success was starting to become worldwide. People modified this and said, well, we got metal and plastic that seems to work well. Marmer's really the gentleman getting credit for most of this, but McKeever and McIntosh came up with this around the same time. Again, metal on plastic. They were really doing partials, just one side of the knee. Statistically, most patients only get arthritis on the inner half of the knee. Eventually, it goes throughout the other portions of the knee. In Europe, they tried hinged knees because the knee basically works like a hinged joint. The problem is anytime you have something that hinged and constrained, there's a lot of transmission force that goes through the implant to the bone, and eventually those loosen. They've improved on those in the years, but even now we still make that the last resort. In the 1970s, John Insull started the total condylar knee down here in the right. This is really the predecessor to the modern knee replacement. Ironically, the Michigan connection is Charles Townley up in Port Huron, came out with it the same year. Obviously not as glitzy as New York, doesn't get the press and glamour, but all the studies and reports have shown he came up with it at the same time, had a separate model, and actually still has a small manufacturing facility there. And he's a Henry Ford grad, if you didn't know that. Lots of variations, many didn't work. Again, look at an interposition here, a piece of metal that was crammed between the bones. You can see the side view of this knee replacement didn't work well. The instrumentation, the balance of ligaments, and I tell patients now, anyone with the modern instrumentation could put metal on bone. It's balancing the ligaments. That's the stuff you don't see on the x-ray that makes it feel like a normal knee. This is just an example of one of the original instrument sets. It was one tray with small, medium, and large. And if you weren't a small, medium, or large, you had to make it work, and no one really fit those. A lot of the implants nowadays have 8 to 12 sizes. You're never more than 1 millimeter or 2 millimeters away from the next size, so you're only shifting things a slight amount. And it's less eyeball carpentry. They literally used to make some freehand cuts, just kind of mark things with a marker and cut areas. Obviously, it's getting to be more precise than that with cutting jigs and now robotics. You can see plastic in the bottom left. This plastic used to wear out in the 1980s and 90s. We figured out why. It was more of a manufacturing issue, so they're making them better now. They're cross-linking the polymers. They're storing them in better environments where they're not degrading on the shelf. So a lot of these plastics were starting to degrade before they even put them in the body. So anything before 2000, we keep an eye on. It's at risk to have plastic wear. It's the type of plastic wear that eventually causes the metal to loosen. Anything from 2000 on is the newer generation of plastic, again showing unmeasurable wear. This is where we're anticipating getting many decades longer, and 15 years out we are seeing that. So we're getting to be more aggressive in doing these in younger and younger patients. We're not telling you, come back when you're 65, deal with it for the next decade. And sometimes even getting down into the 30s or 20s with our rheumatoid patients and not nearly as worried as we used to be. Knee replacement movie. Again, you can see how it works like a hinge joint. Replacement's more of a resurfacing, so there's only about 1/4 inch of bone that's taken off. Cap it with metal, and then plastic in between. So a lot of patients mistakenly think knee replacement is you cut out the whole knee and it's a giant piece of metal in there. And reassure them that's more of a resurfacing. Mako is one of the premier companies now with robotics. They were really first to market with this. It's been out about a decade in some form. The real robotic arm is really this console. It's an interactive system, so it's not like a robot does the surgery. It's basically a smart tool or smart instrument for the surgeon. Stereotactic feedback based on a CT guided plan. So basically what it entails is a patient currently gets a CT scan. We create a 3D model of what their joint and bone looks like. So on the computer we can virtually perform the surgery a dozen or 2 times before, pick the proper size parts that fit their bone, manipulate it, and move it within a millimeter of where we want to. And then the best part is during surgery we can reproduce that within a fraction of a millimeter precision. So even the way we do things now with saws, chisels, it's crude carpentry. That's the way we've done things for 40, 50 years. Robotics is really where the manufacturing industry has gone. You can do things much better than the human hand. You can get within a fraction of a millimeter, within a degree or 2. We know now even with our cups we're getting within 10 to 15 degrees, but this really gets you within a degree. You can argue how precise do you need to be, but I think if we're shooting for a goal and you have tools to make you get that very accurately, it's going to be the way to go. Since it was acquired, Mako was a small startup really for partial knees. 2010 or 11, they added in the hip application, and as they were working on the total knee application, Stryker came in and gobbled them up. Again, it's a Western Michigan company over in Kalamazoo. They saw the potential in this full knee replacement, which we should have available later this summer, hopefully, and the full package, meaning this is a modifiable platform. This isn't a one-trick wonder. They're working on adding in ankle replacements, shoulder replacements, as well as multiple other procedures. So like I said, it's a smart tool rather than a robot, if you think about it like that. The way it works in surgery, for example, if we look, this is the robotic arm and a little burr, so just like your dentist uses to burr down bone. Say for a partial knee replacement, we put 2 pins here with small arrays, little plastic discs on them that reflect. So the computer console in the back sends out lasers across the room. So even if the leg moves, the patient coughs, I have a seizure midway through the case, the bone moves in 3D with the robot. So if I'm cutting in one area and it drifts one way, it drifts with it. And it's a 900-pound robot that's basically steering where I need to go. So if I try and push it out of the way, it's trying to steer me back into it. And if you get within half a millimeter outside where you're supposed to be, it gives you red feedback. So we're doing a lot of our surgery looking at the TV monitor rather than the bone itself once we create a safe portal. And if you go and error and get outside of that half millimeter and get to a millimeter, it literally shuts off the burr. So it kind of idiot-proofs the surgery. There's no way you can be more than a millimeter off. We're able to do some of these things through smaller incisions. I could tell you through the partial knee or unicompartmental knee development, historically they were very iffy surgeries. They're actually technically a lot harder to do versus manually. They've had up to twice the failure rate, meaning revision rate, as total knees. So a lot of surgeons had abandoning these in years. Certain patients and certain surgeons around the country were getting great results with these. Like one of the guys I trained with in Boston, most of his career for 30 years was the uni guy for the Northeast Coast and was lecturing internationally. But even his apprentices that went out and started doing these couldn't match his results. So some people were good, some people were not. Newer studies for those that were good are showing partial knee replacements are lasting as long, if not longer, than full knee replacements. So a lot of that has been debunked. And now that we get good studies rather than just x-rays on knee replacements, we realize 15 to 20% of our knee replacement patients aren't entirely happy. If you've seen anyone with a hip replacement, generally they're very happy. Some of the knees are stiff. When you take out the ACL, there's always a little bit of slide in the knee, so knees are not as perfect as our hip replacements. Most patients that have a partial do feel close to perfect. So they talk about a forgotten knee score. It's a test basically saying how often you think about your knee. Most patients with a partial, the majority of the time, forget they even had surgery. Where when you had a knee replacement, you always know it's there. It's good for pain control, but particularly for high demand, pivoting, cutting, athletic events, anyone that's a candidate for a partial, now that we have reproducible ways to do this, it makes sense. And early results now at 3 years, 5 years out in Europe are showing a fraction of the revision rates. Meaning what used to be at 3 years, around a 3 or 4% revision rate, sometimes up to 6 or 7%, are getting down in the 1.5% rate. So these are very good technically done surgeries now with robotic assistance, which is why I think we're going to see a lot more partials nationally. Again, just looking what a partial does on the left, you can see metal, plastic. The advantage is you keep the ACL, goes right down the center of the knee. With current instrumentation, that all gets cut out to do a full knee replacement. The goal is hopefully with time they create a tray that's reproducible to leave that, and even full replacements can keep their ACL if it's functional. We know about 30% of patients by the time they go on to full arthritis and get a knee replacement do not have a functioning ACL. So this is more for the subset of patients that have this. But this is an example of the images during surgery. So we created the green is where I'm burring, knowing exactly where it needs to go. When you get to white, you're where you need to be. When you start to see red, you're a 0.5 millimeter beyond where you should. So it's freehand, but it gives you resistance, so it starts to tighten up as you get outside there. And we also get soft tissue ligamenting, so we get feedback and grafts. So it used to be just shoving in different size plastics, moving the knee around, saying, that feels good, that feels about tight, and that was very subjective. We actually have quantifiable numbers. We know, is it a millimeter, 1.5 millimeters at this position? How much does it open up? What does the ligament balance feel like? And the best thing is every one of our x-rays looks like that in the bottom right. So years ago, if you were slightly tilted a couple degrees this way, a couple degrees that way, those are the ones that with a very small piece of metal would eventually loosen. It would take you 5 to 10 years to do that, but that's where the unpredictability with partials would occur with the current manual instruments. Total hip replacement with the Mako, again, allows for cut placement within a degree or two and a millimeter, so we can actually plan on CT. So we can take 3D slices in the upper left of the bone. That green is the proposed implant. I can tell exactly before I start the surgery that I want it 40 degrees this way and 20 degrees this way. And if someone's not 20 degrees and they're 28, we actually put it at 28. So you can change that. And in surgery, we register the bone with a little probe. Click on this, and the laser communication goes back to the computer console and registers that patient in 3D space to the model that we created on CT and verifies it. So then when we actually ream through the robotic arm, it'll steer it for us, and it'll actually stop us right where we get to be. It also gives us that green-red color feedback because you can't see on the other side of your instrument, so you know what's on the other side of that as you're preparing it to know where it is. Some earlier studies are showing earlier hip scores and activity 1 year out, but again, hip replacements all do well, whether or not you do them without robotics or not, whether or not you do various approaches. I think this just minimizes the margin for error, and when you're talking the high 90s as far as success rate, may push that up to get to that 99 that we're all shooting for. And it gives you leg length, so the thing I found it most useful for is you get real-time feedback. I know not only degrees, where is my cup at, where is my length at, but I also know when I'm trialing things, how long is that? Is it 4 millimeters or is it 8 millimeters? And I can adjust that within a millimeter of where I want it. Just an example, it will give you the x-ray before you actually complete it, so it's so precise that there's different imaging modalities you can look at. So I know before I even sew up the skin, the x-ray is going to look like that, and sure enough, you get the recovery room film, it looks like that. Knee replacement, again, it was improved by the FDA in 2005. They took their time gradually perfecting the route. They didn't want to rush it out until it was a smooth process for surgeons to use reproducibly. It doesn't use these miter boxes that we currently use at all. It actually freehand saws. And at the tip of the saw, as you look at the monitor, you get to the edge of the plantar section that will stop you, again, within a millimeter of where you intend. So if you purposely try to cut something or a resident leans in a little too much behind something I can't see, there's no way they can cut a ligament, no way you can cut an artery. It really keeps you within very tight confines. Preoperatively, you can pick the sizes. It does save you some time and error from that reason. And down the line may allow for some other ACL sparing implants and other approaches to this. Again, we talked about other utility for the ankle, shoulder. There's other companies with robots, obviously. Spine has a robot available. I think we're going to see this jump out in other facets. It's quite different than Da Vinci. So Da Vinci's got a lot of press over the last decade. That's where robotic arm is in the patient doing soft tissue surgery, and the surgeon's 5-10 feet away at a robotic console in a nice leather chair, steering things with a joystick. It basically scales down the movements to very precise. This is something where we're right there in the wound doing things, smart tool with feedback, so a little bit different. Anesthesia and pain control, beyond all the implants, and you can argue whether or not robotics is going to be a huge game changer. It certainly is in the partial knee replacement world, but this, in my opinion, is probably the biggest improvement. Pain control, particularly knee replacements, used to be very painful. We used to just drug patients up for a couple days, ride out the storm, and then start walking them. They'd be in the hospital for a week. We used to admit patients a couple days, a day or two before surgery, only 10, 15 years ago. So there's quite an evolution in how quickly we're getting patients moving. The spinal is really the way to go at most centers. It's an injection in the lower back. The legs are numb for a couple hours, so patients are still taking a nap. No one likes hearing the banging or the music that we're playing, but they're not on a breathing machine. So they wake up feeling pretty good. They didn't get a lot of the strong medications. They don't feel nauseated. They don't get the sore throat and hoarseness that you get sometimes with the tube. Once the spinal wears off, and we're using some shorter acting agents now that hopefully will allow people to do that sooner. Once the spinal's worn off, we get them up and get them moving. As far as other pain control, 5-10 years ago, we were doing more nerve blocks in the upper thigh, shutting down the pain nerve that gives you feeling for the front part of the knee all the way up here. The problem was it shut down the quad. So patients were very weak. Their knees would buckle. There's a big concern getting people up early because of that. So as we fine-tuned and adjusted dosages and used knee immobilizers at times and do some of the things to make that safe, we realized we're probably overshooting. Why not go farther down to where the nerves are actually acting? It's moved down to more adductor blocks, and most of us here are using just periarticular injection. So it's just locally numbing up all the soft tissues, kind of like a wheel block around the knee. Seems to be just as good. And again, it doesn't shut down any of the muscles around. Multimodal analgesia, we give people a handful of pills even in pre-op. So before surgery, we're starting pills. We're continuing this afterwards. We're not just making them as needed. So 10 years ago, we used to hook people up to PCAs. Again, narcotics not good, nausea, constipation, ileus, all the things that we'd see with that. Now we're coming at the pain from multiple different angles. So it's not just narcotics, it's anti-inflammatories, Tylenol, nerve agents, using ice. Moving has been shown, so earlier you move patients, the less pain they're in. So all these reasons are what encompasses multimodal analgesia. And we're continuing these right through home. Enhanced recovery after surgery is one of the anesthesia terms that, again, that go along with this general rapid recovery concept. Minimal effect anesthesia, you want just enough to get them through surgery, but not enough to cause problems later in the day. You need adequate pain control with good motor and strength. And you don't want nausea or urinary retention. Currently not using Foley's. Encourages patients forcefully to get up to go to the bathroom. I think now our therapists have done a great job leading that route. Our nursing crew has jumped on and is much more comfortable getting patients up on their own even before therapy sees them. So once you get this culture change, and Spine's currently doing this on their unit, get this culture change that, hey, patients can contribute to their own care, nursing can get people up, I can get people up, PT can get people up, so whoever's around can get them moving. And you get these patients moving before they even realize how they had surgery. It's really a downhill battle after that. Currently 80% is our last report, go home in post-op day 1 here, which is far and away higher than pretty much every other place in this area. Some outpatient or same-day surgery, again, is starting to become more prevalent. Dressings, you guys will see, we don't use TED hose anymore. Studies haven't shown any difference. We do use the SCDs in the hospital. There's even a mobile version of those. Some places do, so you may see those at some other settings. Dry dressings we're only using in oozing wounds or those that can't be contained with this type. Aquacell is just one brand that we've been very happy with. It's a company that also makes most of the colostomy dressing, so the adhesive, that brown adhesive, is very benign, doesn't cause a lot of skin reaction, and it stretches and bends. And for colostomy, it seals watertight. So when you put it on the knee or hip, again, watertight seal allows patients to get up and shower right away. Keep these on for a whole week. It's got a very small dose of silver in it, which is antibacterial. So anytime there is a little bit of oozing, you will see a little red, or it discolors whatever color of the fluid that comes out. You will see a little bit in the dressing. It actually swells up and creates a jello or jelly type of material, and that will actually get down into crevices within the wound, dispersing more of that silver. So it keeps that stagnant fluid from harboring bacteria and really sterilizes that area. Studies have shown decreased surgical site infection, reduced skin blistering, compared to the tapes and other things that we use. certainly reduces the frequency of dressing changes. I think that's a big floor issue. So when we were doing daily dressing changes, everyone washes their hands before and after every encounter, but there's always some cross-contamination from room to room, patient to patient. This really seals it from the operating room to the time you get them home. It gets you outside of that window of all the hospital bugs we run into. And it does reduce delayed hospital discharge and readmissions from some aspect, just because you aren't worried about wounds. You can see it, you know what's going on, and when patients go home, they feel more comfortable managing their wound. You guys see them the first day, but after that, they sometimes get concerned. They're unsure. They just bounce back for questions. So we've done a good job teaching how to use these. These aren't foolproof, though, so occasionally if these get saturated, and if you haven't seen one, saturation means it gets all the way to the edges. So a little staining is okay, and it should stop there. If you see one that's questionably getting close to the edge, it's probably good to give a phone call the next day to get an update from the patient. If it gets all the way to the brown edge and starts creeping up the sides, that's a sign that jelly has gotten saturated. That's a point that it needs changed. So you don't want it to be ballooning up. It's no longer gelatinous. It is liquid, and it could cause some skin maceration. If it gets large enough, occasionally it will leak out around this too. So if the patient has a leaking aqua cell, universally it's because it's saturated. Generally those ones, if we get them the day that they're here, we take off and just put dry dressings on. So the old-fashioned 4x4s, ABDs, whatever you have available, put on, have them ice, elevate it. As far as what to do when it's saturated, I again tell patients dry dressings 2 to 3 times a day, change it if you need to. Stop the aspirin or any of the offending agents, assuming they don't have a high-risk factor like Coumadin for a heart valve, other hard indications for it. And avoid bending. So our therapists have been good at saying that's an at-risk wound. Let's wait a day or two till the skin stabilizes, then we can get caught up on the knee flexion. And usually that takes care of it. Drainage in general has been minimized not only by these type of dressings, but switching to aspirin. Universally, all of us replacement specialists have gone to aspirin. Historically, it was always Coumadin. People would overshoot their Coumadin and get problems from that. Then Lovenox paid for a bunch of studies that showed there's a lower incidence of DVT in the lower leg with Lovenox. There's never been any conclusive study that shows a DVT is correlated to a PE. A lot of the PEs are hypercoagulable conditions elsewhere. The thought was if a DVT in the lower leg grows all the way up the leg and breaks off, that goes to the lung and occasionally can kill patients. So aspirin was used just before Lovenox, had great track record. In the medical legal environment that Lovenox came to play in, it was firmly recommended by the chest physicians. This is the main drug we need to use. We went through a 5-year period of using this, got a lot of wound infections, oozing, complications, not much difference DVT rate or PE rate. And PE rate is really all the surgeons care about. We just don't want to kill patients. A blood clot in the calf we can live with. And there's newer studies now showing even a blood clot in the calf, swollen legs, we get calls frequently from swollen legs in the calf, maybe, maybe not, is a blood clot. A reason to have a Doppler ultrasound is not necessarily for swelling, it's not for pain, it's not for swollen toes. Every one of those patients will get those. So 2 years ago we ran our ER visits for patients that were sent to the ER for roll-out Doppler, and we had 88, I believe, and 0 of those patients had a blood clot. So I think just with the rapid mobilization, the aspirin that we're using, even DVT itself is becoming a very rare event. And again, we don't care so much about DVT, we care about PE. So universally now aspirin is accepted by the chest physicians, the surgical associations as being as good or better with a lower risk for complications for PE. Still has a slightly higher risk of DVT, but again, down in the calf, we don't care about those. So every patient, unless they're high risk, gets aspirin, and this is the main improvement for the lack of oozing. Joint longevity, patients will ask, how long is this going to last me? 2000 to 2009, that decade, the fastest growing segment in joint replacement was in the 45 to 65 crowd, 123% increase in hip replacements, almost a 200% increase in knee replacements. Plastic wear I touched on, again, very minimal. That's been the game changer as far as longevity for these. Assuming the plastic doesn't wear out and there wasn't a technical problem putting in initially, or infection, then we shouldn't see significant revision down the line. What used to be a 1% revision risk per year, so when you were 20 years out, there's an 80% chance your joint was going to be doing well. That's now pushing up into the 90s, even mid to high 90s with some of the implants. Hip fracture I touch on, more for the patient talks, similar type of crowd at times, but similar treatment. So you break a hip, you either get a hemi, which is this right here. It's a partial hip replacement. Their socket was fine. And these are for fractures that occur just under the ball. That's an area with not very good blood supply. It doesn't heal predictably, so we just take it out and replace it. Versus an intertrochanteric fracture, a little farther down, more at the elbow part as it comes down into the shaft of the femur. That has good blood supply. Treat those with a nail or a sliding plate and screws to hold that where it needs to be. Within a month or two, that will start to gel down and solidify into one bone. But similar type, we get them up walking the next day. It's really dependent on what their mobility status was prior, so I always have a discussion, particularly with our very frail patients, and you guys feel free to do this too. Oftentimes this is a warning shot of overall medical decline. So we know studies show 1 in 3 patients are not alive a year after surgery, and that's not from this. It's from the overall decline. Patients aren't eating. It's a sign they're balanced, they're slipping, their cognition's not there. So we can all realize and just eyeball a patient that this is going to be one of those high-risk patients, but when it's one of your family members, sometimes they don't even think about that. So I think it's good if they introduce that early. I do try and have that discussion with patients early, not to say that we're going to set them off to sale now, but we're going to mentally prepare, come up with a game plan. Maybe this patient shouldn't be living at home. Maybe we need to look at an extended rehab. Really get patients thinking and families thinking about this, because it takes many months for many families to come to their senses. But in general, 2/3 of these patients do get back to their prior mobility status. If they were using a walker, they're not going to be using a cane afterwards. Best cases, they're using a walker again. Probably 1 in 3 patients do go down one level. So if you're using a cane, there's a chance you're going to be on a walker. But we're still getting these patients walking. They are in the hospital 2 to 3 days longer, usually just for the mobility, the medical complications they get, but similar type of recovery. And I'll open it up to some questions. Yes?
Okay. Is there any specific criteria from the surgeon's perspective when you decide between the unilateral and the total knee replacement surgery, which is the most important part? And probably just the part B of my question is, hypothetically, do you see patients having 2 partial knee replacement and leaving the functional ACL gives them better functional outcome versus doing the total knee replacement?
On the second ones this year, some places are starting to do that. That's really stretching the technology. That basically was a poor man's ACL sparing knee replacement. You put a partial on each side. I don't think we're confident enough in these to say that you're having 2 of these variables now present and the function is that much better to just do a full replacement. So I think the main thinking still is full replacement if it's 2 sides. They've done some duos where it's a medial compartment and a patellofemoral together, and those seem to be somewhat reproducible. That's still stretching it. 5 to 10 years ago, another implant company did not do very well and was pulled off. They didn't have these robotic means to put them exactly where they need to. So when you disconnect 2 or 3 different implant systems and try and get them perfect, it's very hard to do that. And if you do, maybe it'll work, but we don't have studies to show that. And whether or not someone gets a partial or full really depends on the surgeon, number one, and on the patient, and that's a discussion they have. I know some surgeons, even some that work with us, really don't believe in partials. It is a new concept and something you need to learn how to do. But the historic teaching was it was only for a very defined set of patients, and historically had a 1.5 to 2 times the failure rate. So that was enough for people to say everyone just gets a knee replacement, they're reliable, they're predictable, and that 20% of patients that may not love their knee, there's nothing you're going to do with them. So they just live with it. The downside of the partials, where you do a partial and you get someone that has some pain a couple years later, someone eventually is going to do a full knee replacement because you have something to do. So I think that's why the revision rate was slightly higher. Not necessarily that patient needed a revision and the uni failed. They had pain for other reasons that might be from tendons, other areas about the knee that aren't necessarily fixed with a replacement. So I think there's some realization now that even the failure rates as far as revisions of unis were not necessarily equal. And as there's more reproducible ways to do these partial knees and surgeons get confident in the outcomes in doing them technically, I think you're going to see a lot more interest in doing them. I know the indications, even from the gentleman I trained with who was out teaching them for decades, it was really his level 5 evidence of here's the best type of patient to do this on. It was only about 5 to 6% of knee arthritis patients. That has since been debunked by other surgeons, mostly the Oxford group in Europe, have published studies that kneecap arthritis in certain areas you can ignore and still do just a partial, because most kneecap arthritis doesn't hurt. Weight and obesity is not a main reason anymore to do that, so people are getting heavier and heavier on their cutoffs. Certain other conditions that we used to shy away from, you can do partials on now. So some of the newer studies are showing up to 30% of knee arthritis patients may be candidates with the modern indications for a partial. So it's whether or not that patient is in that 30%, whether or not that surgeon's a believer in partials and has a reproducible way to do that. So I think you're going to see some push from the healthcare environment because it is quite a bit cheaper. It's about half the hospital stay cost, quicker recovery, lower complication rate, lower hospital readmission. So there's all the financial reasons to push people towards that, but currently it's really just dealer's choice. Yes.
Regarding the megaplastics, do we have different post-surgical protocols or precautions when it comes to total knee?
I'm not sure, to be honest, why we have total knee precautions anyhow. It's pretty hard to hurt a knee. I mean, if had patients fall on them. So I know currently I think we still do no twisting, no this, no that. We're trying to get rid of all those. I don't know how to debunk a lot of those historic things, but yeah, common sense stuff. Don't get on a fresh incision and scrub the floors. But, you know, I've had patients do that and they're fine, but I wouldn't encourage it.
As far as driving, do you have specific time frames, or is it patient dependent? Do you want them to wait for it?
It's patient dependent. Most of us are okay driving when you feel they're ready and they feel they're ready. I don't think anyone has hard stops at, say, 6 weeks. I know at 3 to 4 weeks there's been studies showing their braking speed after, say, hip replacement is the same, meaning they can slam on a brake. That doesn't mean they're safe to drive. I've had a lot of my partials drive within a day or two of surgery. Had one of our totals leave a couple weeks ago and drove herself home. She snuck out through the crowd. Told someone afterwards she left her car here and wanted to drive home. Wouldn't encourage that either, but you can do it. It's more for other drivers on the road, and can you defend yourself in the turnabouts around here? And are you off the strong pain pills? So I tell patients if you can bend 90 degrees comfortably and not squirm, and you're off the oxy, most people can drive on the Norco if they're tolerable to opioids. If they're opioid naive, then maybe they should just be on Tylenol. They can go ahead and do that.
Can people go for skiing after total knee replacement?
Yes.
For how long? After how long?
Usually about 3 months. Even hip replacements, we've got skiing. Had people flipping down hills at 3 months. Same implant. Yep, same implant. Like I said, the plastic is built to last now, so we're not really changing much. For hip replacements, we'll sometimes use a larger ball, do different things to make it more difficult to pop out. But even at then, hips are different because they're on growth. Takes about 3 months to reliably be confident there's on growth onto the metal. So I've had patients, only one that I can think of that went back to his bowling league at 6 weeks because he felt great, hadn't yet had that biologic on growth and created a torsional fracture. So you want the biology to heal. Knee replacements, because they're cemented, it's more just fixing the soft tissues and can they protect their knee and not buckle and get into those problems.
Extra stress from the process sometimes the patient has like after hip replacement, they feel that their leg is a little longer or something like that.
Usually it is. So we generally like patients between 4 to 6 millimeters. It's not enough to know. I always try and pre-warn patients ahead of time, even if we only lengthen you 1 or 2 millimeters. Usually we're shooting for 4 to 6 just because it gives you that extra stability. It's going to feel long. So arthritis is short. You lost that ball and socket padding, so we're bringing you back where you used to be, plus a couple millimeters. And we're increasing the offset. So the abductors are artificially shortened. After surgery, they're stretched out. So most patients are stuck like this. So when you're stuck like this with tight muscles, you tend to walk like this to not stretch those muscles, and it hurts. A couple weeks from now, once those muscles stretch out and you can get your leg straight, your pelvis subsets. People that do not sometimes have a fixed suprapelvic obliquity, we call it. It's basically back arthritis. So when your hip was in one position, you have arthritic back, it gets stiff in that position. When we change the dynamics and the kinematics below that, it's up to the back to loosen and accommodate that, and some patients won't. So some patients, despite their leg lengths being equal, will fix and change their position based on their back, and some won't. And those are the ones that get into problems down the line.
After total replacement, there is sometimes very click.
Yes, so all knees have a click. There's 2 styles of knee implants. There's one where you cut out the PCL behind the knee and replace it with a plastic post, and there's one where you keep it. I prefer the one where you keep it. I think the most natural type of knees, leaving the most in, has a little less click laterally. It seems to be a little tighter in flexion. Particularly if you cut it out, there's a little bit more of a mechanical bend to the knee. Laterally, I tell patients the outer half of the knee, their upper knee, if they do this with their foot off the ground and the muscles are relaxed, does open up 2 to 3 millimeters laterally. Medially, it's a very tight ligament. Laterally, it's more like a rubber band. On a normal knee, you got padding, but with replacement, you got metal and plastic. And different knees, different styles, different implants, different techniques will have a little bit more of a click than other. Usually it should be minimal, and most patients, if they have good muscle tone and are walking on it using their body weight, will have minimal clicking because that compensates for it.
Yes, something like reduced osteoporosis causing neck pressure. Would that osteoporosis affect other hip structures or stuff like this?
Just seems to be the neck is the weak area.
But it makes other bones weaker.
Yes, you get spine fractures, compression fractures of the spine, distal radius fractures, a fragility fracture. So there's 3 or 4 fractures that are fragile bone warning shots, if you will. So those are the patients that should be getting a bone scan, DEXA scan, bisphosphonate treatment, follow-up afterwards.
How about the, the hyperflexion posture, like, after patient is able to attain that much flexion? I mean, is it safe to do, or?
Yeah, you can't hurt the knee. Basically you get to the point that you're standing like this, you bend enough to where the back of the tibia hits the back of the femur.
Like you're squatting down, like in or Muslim prayer
Yeah.
or yoga?
Yeah.
you squat.
So about 10, 15 years ago, Zimmer, one of the big 3, if you will, companies out there, had a high flexion demand knee. So it was built, had a little greater radius or smaller radius of curvature on the bending. The thought was it would allow you to turn the corner and bend more. So particularly in the Middle East, they were seeing 150, 155 degrees of flexion. They brought that to the US thinking this was a better bending knee. Studies show no different. So unless you're Muslim, bending have hyperflexion to begin with, you're not going to have hyperflexion afterwards no matter what implant you put in. So we always tell patients if you got good bend before, you're going to have good bend if you work hard afterwards. If you didn't, it's going to be a struggle to get that, regardless of the implant.
How about the groin pain?
Yep, afterwards, number one thing I see after hip replacements, trochanteric bursitis. So you'll see that every patient gets it once or twice in the first year. Number 2 is hip flexor tendonitis, and that's usually that groin pain. We are poking retractors in there. So from the back, there's one that goes in there. From the front, they're taking out and irritating a lot of that capsule that rubs. So the iliopsoas tendon comes right in front of that capsule, so there's a little bit more scar there. So regardless, you're buggering up something in the front. Just tell people anti-inflammatories, work on your hip flexion exercises, stairs, things like that. Or sometimes patients even have to pick up their leg and move it to get out of a chair and car. That will settle down, but it's very common. The knees, the other thing you will see, the most common thing after knee replacement is patellar tendonitis, so pain in the front, particularly when they go downstairs, when they get up from a chair. Number 2 is pes tendonitis on the inside of the knee, hamstrings. And number 3 is the IT band on the outside. So there's some pretty common tendon issues we get after these surgeries. Usually they burn themselves out in the first year, occasionally 2 years. So I always tell patients it's a 1-year recovery. 90% of it will come in the first 3 months, but those last 10% will come.
How about the total hip precautions for every approach? Still in place, like the twist and...
I'm not sure what they are. We keep trying to gradually get rid of these. I personally don't care.
Okay.
Other people are a little more hesitant and conservative. I think we'll eventually get there. We're trying to basically keep it to no excessive twisting, use common sense, no excessive twisting, but the whole 90-degree, can't do this, can't do that. I mean, there's even people out in the community that do 90-degree for life. It's not practical. We know a lot of these patients don't listen to what we tell them anyhow. If it's a high-risk patient or revision, yeah, we maybe really sync those patients, but for normal primaries, it's more of a precaution to slow them down. If they need to cheat a little bit, put their socks and shoes on, I tell them, hey, that's fine. If you're going to go down, go between the legs. So I always tell my women, if you're sitting, sit like a guy, open your legs up, come down like this. This is a very safe position. What you don't want to do is obviously twist in and down. So I let them know in surgery, the only way to pop these hips out from a mini posterior superior type of approach is to bring it up well beyond 90, twist the knee in, and twist the foot all the way up 90 degrees. So it's got to be pointing 90 degrees that way. And that's with no muscles healed. So within a couple weeks, there's no reason anyone would be doing that. So I always encourage them to spread their legs when they bend over. Anterior hips can pop out from the front, actually do pop out from the back as often as they do from the front because people release the back. So it's basically extremes. There's no right or wrong for any one approach. I think just use common sense for a couple weeks till you get your muscle control and muscle stability of the hip.
Revisions that you do on one patient. Someone who started bedding because of an accident or something like that. And then
Do as many as they'll tolerate. We've got some patients that are 10 to 12 time winners. You don't want to go that route unless you have to. But eventually you run out of bones. Every time you revise, you take more and more bone, more and more metal. You got patients, even the tumor world especially, where you end up with a total femur. So you got a hip replacement and a knee replacement and metal all the way in between, so you literally have no femur. So there's technical ways to do a lot of these things. The predictability is a lot less, and the complication rate's higher. Obviously, infection. The more metal you have in, the more chance for infection. That's really the difficult. It's minimal. It's a fraction of a percent. So I ran my numbers. I was outside. I had a particular implant issue for years prior, but outside of that, for a 5 or 6 year period, it was at 0.1%. So I mean, it's a tiny, tiny percent. Most surgeons are under 1%. We did have a period of time with a faulty implant where people were up in the 3, 4, 5% range. But again, these are very, very fall. And you can eyeball the patient. They're usually, someone who's not mentally cognizant, not taking care of themselves, really doesn't know where their leg is at in any position. Anyone that's mentally competent isn't going to be doing anything crazy and has good control of their hip. Should be fine. We're not getting those over-aggressive rehabbers that are popping out because they're doing too much. It's usually the mentally deficient patient from that standpoint.
With all these improvements, is there any reason that why we're not going bilateral at the same time?
I get patients come in and ask for it, and I've done it. I've seen results both ways. I tell people it's a miserable recovery. Really no difference. So you could do both in selected patients. The thought was higher death, complication, heart-lung rate. Newer studies are showing in healthy patients, no different. So you could do it. It takes you 3 months to get better. So anyone that's in a rush to get it done, I tell them do one, and then 6 weeks later, we already have it scheduled to get the other side. So you've always had one good leg to lean on. So by 3 months, you end up at that same point. If you do both at the same time, you're guaranteed to go to rehab center. Much higher chance of needing transfusion. You don't get a chance to build your blood levels back up. When you're in Boston, you got people flying in from Europe and Seaman Fellowship because they're in town and want to get it all done. That makes sense. But if they're local and can come back a couple weeks, even the partials I've done 3 to 4 weeks later because they're a little quicker recovery. A lot smoother of a recovery process.
what's the time period for lateral approach? When can patients start with active abduction?
Lateral. A direct lateral depends on the surgeon. 6 weeks minimum. Some people went up to 3 months. So you're pulling directly on something that's sewn by stitches. So biologically, it never heals normal. People take off away for a bones, maybe bone to bone heals quicker. So there's some other adjustments people have done. But those are the ones you got to be cautious. Really, just a direct lateral is the only one you need to worry about abduction-wise. Any other approach, the goal is to do abduction.
Since they started the new program of 3 weeks of home therapy and then go for an outpatient evaluation, do you have any feedback? Like, are they going to outpatient, or are they just going home for exercises?
I don't get that feedback, to be honest. What we're trying to do is debunk some of the you have to do this, you have to do that. I mean, the one-size-fits-all protocol is not the way of the future, and it doesn't work. So patients that are doing well, there's some studies showing you don't need any outpatient therapy if you do a couple weeks. There's some studies showing you don't need home therapy. You can just go right to outpatient. There's some studies with computer modules on your iPad. You can do it on your own without. Obviously, those are select patients. So I think the one-size-fits-all approach is not ideal, and that's what we're trying to do, particularly our hips. Our hips universally do great. One of our surgeons downtown for a couple of years has not used much outpatient therapy, and I'm sure patients do just as well. So it's up to them. Patients that are going to sit on the couch all day absolutely need it, so a lot of it's deciding who that patient is. Patients that are already back to work at 3 weeks, do they really need to take time off work to go to therapy? Probably not. A stiff knee, yes, absolutely should be. So it's hard to protocol things like that when every patient's not cookie cutter.
Questions?
Is there anything from your standpoint, if a patient comes in for their follow-up push home therapy would talk to them more about this. I didn't know if there was anything just in general that as home therapists.
Particularly, no. Other than just getting rid of the rules. I'm kind of more the rebel of the group, but until I couldn't drive till I saw you, so I'm trying to get rid of that. I can't do this, I can't do that. The goal is if you see a patient that's a rock star, let them go with it. You know, I can't get off the cane until I see you. That's the same patient you leave is driving the grocery store with nothing. So I think we can give them rules, but the medical legal cover your butt, overtreat everyone just to say you did is not the way it's going anymore.
You're just mentioning about the ER visits, so
ER visits, yes. So that everyone sees anyone. The goal is not to go to the ER. So the hospital right now, the CMS Medicare reimbursements tied to readmission rates. So obviously it's not good for patients. Most of them come back more for social visits, get a bunch of tests. Occasionally they find things like a lower leg blood clot, which we don't care about, but again, double penalizes us because our blood clot rates go up. So there's a big financial impetus to avoid that. So we're having patients call. We've got a hotline number now that someone should be answering 24/7. We got these little nice magnets we can give patients to have an easy go-to number. And hopefully you guys can get a hold of us. If you're having any difficulty doing that, just please contact me or anyone in my office. We're trying to improve that. Nothing's worse than the call center. We hate it as much as you guys, as much as patients do. So going through 10 people to get a call back 2 days later is not ideal. So we're trying to get back to people right away. Again, swelling is not a worry. It's the biggest thing to debunk. And dressing issues, stop the blood thinners, avoid the bending, put new dry dressings on it. I think everyone's bringing some dressings with them now. Occasionally I'll get a call where someone showed up with nothing. That's frustrating as a physician, because what are you there for? You're going over meds, you're educating, but if you can't do anything when you're there to assess a wound, make sure you at least got some gauze, some tape. I like ACE bandages if you have access to any of those, sometimes a little easier than tape. That way they can reuse it and not use tape at all. We can always get those patients stuff in the clinic. So I tell patients, you know, if you can bandage it, go to CVS, throw some things on it tonight, come into clinic tomorrow, and the front desk will be anticipating you. We're getting a better mechanism where we're giving a heads up to the next day. So even if I'm in the operating room, someone else in the office will be available to assess the wound, give them a handful of ABDs and an ACE bandage. And pain pills, multimodal pain pill continues through home, so educating them. Nikki's got a great sheet she put together explaining that, but the biggest improvement therapy-wise, pain control-wise, is educating them on how to use their pills properly. So if they're gun-shy with it, even though our bottles say Oxy and Norco don't take together, you could. It's more of a cover your butt type of scenario, and for patients that would take them all in the same glass of water. So I tell patients space it out an hour or two. So if you're taking 2 Oxy every 4 hours, but 2 hours into that you're miserable, you can take Norco. Just don't take 2 Norco and 2 Oxy all at the same time.
So how do you educate patient about the primary prevention? Because I have seen people swelling that they hurt about primary doctor.
Yeah, that do not call the primary care doctor. They don't want to deal with it. We don't want them dealing with it. Pretty soon they're getting CT scans, roll out for PE, and they're on Vanco and the CDU. So the goal is to get them in our arena where we know what to do. We're comfortable watching things that other people are not. So what looks like a red cellulitic infection is normal to us in most patients, but if you don't see these all the time, you don't know that. So the goal is really to try and get them to us. And a lot of that was the communication gaps, so we're hopeful we're improving those.